Okay.
Good morning. So welcome to this morning's discussion on the Seinfeld episode of suicide. So people in the room don't need to log on to Zoom, so we're good. Where would you like to start?
David.
All right, I could find the right contract.
Good morning. If you want to go around, yeah, I want to push this over because we're streaming live. I just want to make sure you're okay with in front of the camera here. So we're just talking and introducing this morning's Psyfeld topic, which is the Seinfeld episode of the suicide. So to ease into the discussion, anything strike you as interesting in watching the suicide last night or this week?
Is it bad to jump to the end of the episode
No.
first?
No.
I thought his skit at the end of the episode was really telling of, I mean, I know he was doing like a comedy skit, so he probably said more like socially unacceptable things than most people would. But I just thought like the skit at the end kind of goes back to what we talked about, how he's like potentially somewhat like self-centered. And he's like, try harder, and just his comments, I think, like really go against like societal norms of how you would talk about somebody who had a suicide attempt.
So let's talk about the idea of going against societal norms, especially in this particular instance, in this character, right? And we're going to say that the comedian at the end is in character, right? So we'll keep it consistent with the character. Any further thoughts about how Jerry is struggling with some thoughts or feelings that then become manifest in what he does and what you viewed, what you saw?
He's actually fairly sympathetic towards the idea of like depression and suicide in general. Like he's not like saying, why do people kill themselves? That's not what he's saying. He said, why don't people do it successfully, which is like obviously a ridiculous thing to say. But that kind of points to, I think he might at least consider that it is like reasonable and maybe even be suffering it from it himself based on his attitudes. His attitudes are obviously like over the top, but he's at least sympathetic to the idea that why would a person consider even committing suicide?
And there are other episodes where this issue is addressed. Again, I don't know if you've seen all 9 episodes, but there's even an episode where there's discussion of Newman attempting suicide or planning to attempt suicide. So this is an issue that this situational comedy tackles, right? Which is again a national health crisis. You made a comment about that he might even have considered, or did I mishear that?
Yeah, no, I wouldn't. I mean, there's I think like a stereotype about comedians that a lot of them do suffer from mental health problems themselves. So I think it wouldn't even surprise me if at some point in his character had considered it himself for some reason or another. I mean, that's probably too much of a reach, but
Well, let's continue with this idea. Whether it's him or whether it's someone close to him, there might be something there. What might happen when there's this feeling or perhaps even impulse that the other side of you feels is inappropriate or certainly doesn't even want to come to conscious expression? What might be the dynamic in play here?
Well, it might be like one of those like mature, like coping techniques like humor. But I was also wondering if his like jokes about suicide were like a sign of the times. Like I feel like that kind of stand-up routine like wouldn't be accepted like in 2022. But like when this was created, like that was the kind of humor that appealed to like general public. So I was also like wondering if like it just was the time that was appropriate.
And may or may not, I mean, there are always social determinants of behavior. Every behavior can be analyzed, can be discussed from a biopsychosocial perspective, social, of course, being 1/3 of that. But the other thing you mentioned, I think, is right on target here. We have, and I'm just going to merge the two ideas together. We may have a character here that has an impulse, whether the impulse is his own or whether it's thinking of someone else, perhaps someone close to him. The impulse is not allowed to come to conscious expression or awareness. So you mentioned coping skills like humor, that's a defense mechanism, right? Because the impulse would be embedded in the Freudian id, which we all have. And impulses are deemed taboo. And this is going to relate to the other comment you made, which is something that society or a culture says should not be discussed, should not be thought about. And from that point, there's going to be distress. Because if you have an impulse, if you have an id, if you have a part of yourself that operates along what is called the pleasure principle, and then you have another part of yourself, we'll call that a superego, that operates along the lines of what is called the reality principle. These are two equal and opposite drives. Right? And there's going to be friction. And where there's friction, there's anxiety. Freud actually deemed this conflict anxiety. Now, does Jerry Seinfeld and the character in this particular episode come off as overtly anxious?
I think from the very beginning, we hear about his neighbors like suicide, like when the girlfriend knocks on the door, he's like going back and forth, should I get my room, should I not get my room? Like he's like always like showing those symptoms of anxiety to like when they're in the hospital room, and then like the girlfriend's like coming on to him, and just like it's that back and forth between like the like id and super ego, where he's like really trying, like you can tell he obviously wants to engage with her, but it's like he's trying to hold back, and it's like showing this like anxiousness. And I think that happens with a lot of people when they're dealing with death. Like death is a very like complex thing to talk about, and some people react very differently, and they like and they it's like you don't know what to say. And then again, like how everyone has different coping mechanisms, and then that concept of like joking about death. I feel like now, like today, there's at a certain point when after someone's passed, then you start to like feel more at ease with it, and then you can like start joking about like, oh, they would have done this if they were like still here, type of like humor about it. So
At that point in the episode that you recognized, why didn't Larry David, as the producer of this show, have Jerry then experience anxiety that would have resulted in his perhaps presenting to an ambulatory care clinic or maybe an ER? Why didn't it go in that direction?
he kind of sublimated like his feelings with humor. It, you know, and then it's like a humorous thing, it's like a mature coping mechanism. So like even though he might have these thoughts in general ever, or have dealt with it in someone of his friends, he's able to joke about it and move on with his life, like a lot of other people.
Yep, and that's exactly right. I don't think I would have used the word sublimated, but you are right on target there. We all have an impulse that we're harboring right now. There's several at the same time, and not a single one of you are acting on it, right? Instead, you're in these cleanly pressed white coats, sitting in a classroom, 8 o'clock in the morning on a Friday. And if I asked you on a lie detector, what would you rather be doing? There's no way you'd be able to tell me, oh no, this is exactly where I'd want to be, right? This is your superego overriding that impulse. You're creating, you have inner conflict then, right? And Freud called that anxiety, but again, I'm looking around the room and I think I have a pretty good feel of this. I don't catch anybody who's really being anxious. Now, when you start presenting your patients, all right, it's going to ratchet up a little bit, but otherwise, everybody seems to be sub-threshold here, similar to Jerry Seinfeld. He doesn't present with anxiety as a chief complaint in this episode. And the reason why is exactly what you said, that third and final component of one's personality called the ego. Through the ego defenses, or the ego's defense mechanisms, in this case, it's humor, right? So I think the original observation in terms of what's going on with Jerry in this, looking at that final scene, that final stand-up, really does allow for a window to peek into the Freudian theory, dynamic theory of personality and the use of defense mechanisms, those subconscious processes of the ego that basically end up defining who we are. Right. Now, on a shelf exam, yes, I heard it as well. That is, these defense mechanisms originally classified by Valiant were classified along the lines of mature, immature, narcissistic, etc. And you're probably gonna have to know a little of that. And you were right on this condition. That is, this defense mechanism of humor is one of the more mature ones. However, in clinical practice, there really is no such classification. Defense mechanisms either get the job done right or they don't. And if they don't, you're at risk for developing a mental illness, right? Whether it's mature or not. that means that the most narcissistic of defense mechanisms, when used appropriately, when used constructively, can actually benefit someone. Okay, denial is very, very helpful when in the immediate phase of someone passing. Right? On the other hand, humor, which is classified as a mature defense, can be very debilitating when used or misused. And by the way, we see that in 9 Years of Seinfeld. I mean, he is the leader of this group. His three friends look up to him in some capacity, each and every one of them. He obviously uses humor all the time, which means that it becomes rigid. And hence, it serves as a risk factor. And there's plenty of hijinks in the situational comedy as a direct result of Jerry Seinfeld's maladaptive use of the mature defense mechanism of humor. So something to keep an eye out on. So on tests, yes, you have to know the classification system. In clinical practice, not so much. Questions or further observations about the final stand-up scene in The Suicide? What else caught your eye?
Well, there was the girlfriend, and I thought like the reactions through the entire episode were really interesting from a psychological standpoint, where she was overtly flirting with Jerry to begin with, and then going back to her boyfriend, and then rushing to go save her boyfriend via Jerry, but then saying he could die and I don't care, and then having an affair with Jerry, but then going back to the boyfriend at the end, the sort of back and forth nature of it, the impulsivity. I thought that would be interesting to discuss.
Mhm. Any thoughts about that? Gina, right?
Yes. And potentially a histrionic like personality disorder of sorts.
Why do you say histrionic? Yeah. So individuals who are afflicted with the histrionic personality disorder follow a cardinal trait. And that is that they need to be the center of attention. And if they're not the center of attention, they feel very uncomfortable, and their behaviors will work as a goal towards becoming the center of attention, whether it's verbally or non-verbally. So they, as a group, tend to come off as very dramatic. And that's because of the need to be that center of attention. Just a little bit of a gestalt. When you learn the personality disorders, it's important for you to look at the three clusters. In, again, 2022 in medical school, these conditions are taught as grouping together because they tend to cluster symptoms. So, for instance, histrionic personality disorder is part of cluster B and therefore shares characteristics with other B personality or cluster B personality disorders. And that is true. For purposes of your test, Michelle, it's better to then reorganize and throw everything into a hat and then recategorize as either column 1, where you have a group of these conditions that actually adhere to a common cardinal trait. And an example would be the histrionic personality disorder. And then column 2, those that don't, right? Because as we're discussing these different conditions, the extent to which you could identify the cardinal trait in those in column 1, it'll make it a lot easier to identify in an exam, because the diagnostic criteria then become just examples of that cardinal trait, and they're not necessarily criteria in your mind to memorize. Of course, you're going to have a little bit of a different study approach on column number 2, right? But it's good to learn through the 3 clusters, but then recategorize and study along those two columns. Histrionic personality, column 1. The individual needs to be the center of attention, and then peek at the DSM criteria, and you can see that they are all examples of that driving need. Anybody agree or disagree with Gina having, we'll say, traits consistent with histrionic personality disorder?
I would agree with that, very like maybe that's not attention, kind of like when she interprets like Jerry like rejecting her, so how you agree in there, and like versus like not really, and like I think that it was pretty not good for her saying.
Yeah, I found that dialogue really interesting, and it actually reminded me of another character in literature. which he's actually doing in that scene. And, well, I'll leave it there. And did it remind you of anyone? No, huh?
The answer is so late, so.
It is. It is. Very manipulative. And she actually really plays on another person's, a man's pride in calling him out for not being a man. I couldn't help but thinking of Lady Macbeth. And the irony here, as we just learned last week, is that I Heart Lady Macbeth serves as an acronym to review the etiologies of delirium. And there just so happens to be a case of delirium in this very episode, right? Albeit demonstrated by Elaine. So I found that ironic. Other characters here you'd like to touch base on? Or anything further for Gina?
I think the husband probably got some traits consistent with borderline, or the boyfriend that actually committed suicide, or tried to at least. He was like very sort of like jealous all the time. It's not even, I don't even know if borderline is the right thing. There's like a lot of different things going on, and we don't really get a good sense of his character. But the fact that he's like very jealous and kind of impulsively commits suicide, or attempts to, after the girlfriend is looking at Jerry, there's something wrong going on there. There's like a potentially number of different problems there, but we don't really get a great sense of who he is as a character.
Yeah, it would be nice to see the prequel. I mean, this is season 3, episode 15. It would be nice to see season 3, episode like 14 and a half, so we can actually see if he has a past psychiatric history that would make sense. Because without knowing that, I mean, the absence of it in the situational comedy doesn't necessarily mean that therefore it doesn't exist. So it would be nice to tease that out, because what you're left with in the brief glimpse that we see of Martin, he appears to be without any signs of psychiatric illness, but yet he overdoses, and he overdoses with the precipitant of exactly the scene that you just alluded to, right? So again, pulling back just a little bit, this, I think, is an opportunity to once again review how to case formulate. I mentioned before that all of human behavior, including abnormal human behavior, can be conceptualized as being influenced by biopsychosocial factors. And we've learned that, I think, way back in our first year of undergraduate, right? Biopsychosocial factors. Certainly in medical school, we begin to actually view those factors as predisposing, precipitating, perpetuating. So if you build a 3x3 rubric, you could see that now we had created 9 squares, and we could look at not only biopsychosocial factors, but biopsychosocial factors in as much as they might be part of factors that themselves predispose, precipitate, and perpetuate the behavior. For Martin, we just identified that we really don't know what predisposed. So we don't know what biologically predisposed him to do this, what psychologically predisposed him, nor do we know what socially predisposed him. But we do see a precipitant. And that looks to be the flirtatious nature of Gina. So I'll probably call that social, right? So a social determinant of behavior, specifically a social precipitant to Martin's behavior, looks to be the dynamic that you just actually identified, right? So his actions could be conceptualized not only biopsychosocially, but also influenced by factors that, in this case, precipitate the actual overdose. Do we have any indication as to whether Martin or Martine had a clear intent to die? Okay, assuming that the answer is no, it's only we'll work along this hypothesis. That is referred to as non-suicidal self-injury. Okay, and non-suicidal self-injury can have many etiologies, but along or around the top of the list would be cluster B personality disorders. And one example of that would be borderline personality. So I don't think you're that far off. in terms of conceptualizing this might actually, that is this action, may be part of an enduring pattern of behavior, an enduring pattern that we just don't know because we haven't seen season 3, episode 14 and a half just yet. Any other thoughts on Martin or Martine?
I've been like paranoid personality disorder. This was my first time like watching Seinfeld, so like I don't, you know, have a big backstory, but it's like the way the development engineer reacted was it that like because he was always so like paranoid and like it was when it was going to use it at first that she started to like act out and be more flirtatious with Barry Seinfeld's character, or with like the reverse order where she was picking up on something and she was kind of like gaslighting him the entire time to a point that if you like probably would attempt suicide and then so I thought that was after I was like going with it. So that was like something I think I was like, so what was first, like her actions, like his actions like in the past. So
Yeah, that's a good point. Since we don't know much about Martin, and if he's going to come to clinical, he's going to present clinically in that hospital. I would hope somebody gets a psych consult, status post the overdose. And I think one of the questions anybody in this room would ask if he is one of the first names that are on our list this morning, would delve into the dynamic of what led you up to doing what you did, right? So we know the precipitant, or at least we think we've identified the precipitant, but I would like to know the biopsycho and social determinants of what may have predisposed him here. And if there's an enduring pattern of behavior consistent with the paranoid personality disorder, or even delusional disorder, jealous type, that would significantly impact our treatment planning, right? And of course, medication prescribing. I mentioned this condition, delusional disorder. How do we tease out delusional disorder from schizophrenia? It's about the timing. Schizophrenia is a chronic illness. Chronicity, per the American Psychiatric Association, is usually operationalized as 6 months or longer, and that is true. I believe for delusional disorder, it's 1 month. Right? So there's time, but there's more to it than that.
Delusions are usually these thoughts where schizophrenia, you have like auditory or visual hallucinations. You don't see things other people can't, but delusions are more just like thoughts you have.
But can people with schizophrenia have delusions as well?
That's true, but they usually also have auditory hallucinations.
That's what I'm looking for, right?
Yeah.
The additional symptoms. So someone who has schizophrenia can present with delusions, and but presenting with delusions does not automatically allow the clinician to say, therefore, it is schizophrenia. If there are delusions plus additional criteria, and you need a total of 2, then you're probably looking at schizophrenia. But without those additional criteria that meet that diagnostic threshold, then delusional disorder is higher in your differential, right? And that means that the individual with these delusions that are clinically significant are not enduring any perceptual disturbances. They are not demonstrating any disorganized speech or thought process, nor are they demonstrating any grossly disorganized or catatonic behavior or negative symptoms. That is, they don't have any other symptoms defining schizophrenia. If that is the case, and a person is presenting to you with at least 1 month of these fixed beliefs that are not reality-based, that are causing them clinically significant distress and impairment, what are the 5 subtypes that might present to clinical practice? We just mentioned one, right? Jealous subtype, which might be our character. Maybe. What are the other 4?
it is a delusion if it's actually like he's got a reason to be a little paranoid about it.
No, it's not. No, we're using this as a teaching tool. We're not, yeah.
Like, I forgot what it's like, like
Erratoman.
around, yeah.
Well, medical students have a difficult time pronouncing errata. I think that's your superego. Yeah, I don't think it's a pronunciation thing. I think it's a superego thing, but that's Brandy. Yes, good. One more. Somatic. Right, somatic, right. And then sometimes, our patients do tend to present with behaviors that don't really fit into these artificial categories that we created per the APA. And if that, then other. Right now, you're not going to get, watch, as soon as I say this, you are going to get the question, but you're not going to get a question on your shelf exam where the single best answer is delusional disorder, other. Because the more common types of other delusional disorders that present, and this includes shelf exams, have been named. And they usually take the name of the person that initially identified or described them. And there are 3 such that commonly come up on shelf exams. What are those 3 conditions? Good. Capgras or capgras. What is that? Other than telling me it's a delusion.
People you know and they don't look like them.
Close. They think all of their family members have been replaced with imposters.
Yeah.
Actually, there was a patient on our service recently who had that delusion.
Capgras
I
delusion.
thought all the nurses were being replaced by fake nurses. And stuff like that.
Right. Otherwise referred to as the body snatcher syndrome. It's coming from Hollywood and folklore. You're not going to see that in a shelf. But if it helps you remember, any alien movie in which there's a body snatcher is a metaphor for the Capgras syndrome. 2 more. Fregoli is a variant of Capgras. Fregoli, Fregoli, is the delusional belief that a person can actually shapeshift and take the guise of others. Right. And then there's a third. Cotard, COTARD, Cotard syndrome, which is what? It is a delusional belief that the individual is either dying or a part of them is dying. Right. So that's Cotard, that's 6th sense. At least if you view it for a psychiatrist. Right. No spoilers. All right, we're at the bottom of the hour. Any final thoughts on Seinfeld, the suicide? Yeah, we'll leave it here. We'll say goodbye to everybody on Zoom and look forward to seeing you in about 2 minutes for table rounds. Thank you.